Hello, I'm Jeff Ibbott, and I'm an Associate Executive Director of the American Board of Radiology with the Medical Physics portfolio. We have prepared the video you're about to see to help familiarize you with the ABR's oral certifying exam and the remote platform. This video depicts the oral exam itself. There are a number of preparatory steps that you will learn about by completing your technical check, by reviewing the exam guide, and by attending our orientation webinars. Our video begins at the moment the candidate first meets the examiner and illustrates one of the 5 exam periods that make up a full oral exam. The video is based on an actual exam, but the roles of the examiner and the candidate are played by ABR volunteers whom you might recognize. The questions are actual oral exam questions that were used in a recent exam and have now been retired, so they are truly representative. And the actors portray the conversation that took place in an actual exam with a few edits to assure anonymity. As you will see, the exam is designed to promote a conversation between the candidate and the examiner. The examiner will ask the candidate to read the question out loud before starting to answer. This is to help the candidate focus on the topic, and so the examiner can confirm that the candidate has read the question correctly. During your exam, we encourage you to ask for clarification if you don't understand the question or have trouble seeing an image. And please ask the examiners to repeat themselves if you have trouble understanding them. You'll notice that the examiner's facial expressions and responses are quite impassive. They are trained not to indicate whether your answers are correct or incorrect, but they will say things like, okay, or that's fine, to indicate that they've heard and understand you, or perhaps that they're ready to move on to the next question. Please don't try to interpret anything they say or do as a hint to how well you're performing. I also want to explain that while an oral exam is necessarily somewhat subjective, we've done a number of things to make our assessment of your knowledge as objective as possible. First, the exam questions are written by experienced clinical medical physicists who are experts in the subject area. The questions are reviewed and edited by a committee of similar experts, and a guide to the examiner is prepared to clarify to the examiner what material is to be covered and where the examiner might focus the discussion. Sometimes follow-up questions are suggested, although examiners are permitted to ask their own follow-up questions. Next, shortly before the exam, the examiners meet to review the questions together, to agree on the approach they wish to take and the specific details they expect the candidate to know or not know. During the exam, you'll see that the examiner is apparently making notes to remind themselves about your responses. Try not to pay attention to this. The examiners meet many candidates during the day, and they use these notes to help with their recollections. They will also assign a score for your response to each question. The ABR uses a 5-point scale, with the midpoint of the scale being the lowest passing score. Each candidate is examined by 5 examiners, who each ask one question from each of the 5 categories of the exam. You can review this list of categories in the content guides on our webpage. The examiners ask the questions in a different order to make sure you're asked a question in each category by at least several examiners. Finally, the scores given by your examiners for each category are averaged. Again, this is done to keep the process as objective as possible. And it means that while you might struggle with the question from one examiner in a particular category, you might do much better with another examiner's question in that same category. In this way, it's possible to offset a low score with a higher score and still pass that category. In the video, after each question, you'll hear the examiner and me discuss the candidate's responses. And while we don't mention numeric scores, we use terms like high pass or just failing to suggest the scores that might have been assigned in an actual exam. We hope you find this video informative and helpful as you prepare to take your oral exam. All of the examiners you'll meet have been through the process as candidates themselves and are sympathetic to the stress you might be feeling. They want you to do well, and often their follow-up questions are intended to help you arrive at the answer. Be sure to engage with the examiners and stay focused on the questions. And again, we wish you success on your exam.
Good afternoon. I'm Bob Pooley. Can you hear me?
Good afternoon. Yes, I can hear you. Thank you.
Great, great. Nice to meet you.
Nice meeting you.
Before we get started, there's a couple of things I need to mention. First, may I see both sides of your whiteboard as well as your marker and your eraser? Okay, great. Thank you. Second, and this is very important. So during the exam, please do not hesitate to ask me or any other examiners to repeat a question if you have trouble hearing or understanding us. All your examiners will be very happy to repeat questions as needed.
Thank you.
Okay, so let's get started. I'm going to click on an image here. Let's see. So this question relates to artifacts in PET CT. Do you see the image on your screen?
I do.
Okay, so why don't you go ahead and read the first question.
Discuss the possible causes of artifacts in PET CT images, including 1, PET-based factors, 2, factors associated with CT-based attenuation correction of PET images.
Okay, let's start with the first one.
All right, so for PET-based factors, could I start with 2 actually?
Sure.
Yeah, it's more fresh in my mind. So hopefully as I get talking, I'll get somewhere. So for the CT-based attenuation correction, you could have like a misregistration of the PET image to the CT image. And so that could be caused from like a motion artifact, and that could lead to areas of the PET image which appear to be photopenic because the attenuation of the body was different than what was assumed because of the movement. You could also, if there was a metallic implant, there would be probably a photopenic area because there would be so much attenuation present in the CT image, but the PET image, the PET photons may be more penetrating, and that could create an artifact that way. For the PET-based factors, you could have events which are not true events because they were single events. That maybe the other photon was attenuated or left the screen or left the ring of the detectors, but they register at the same time, so there creates a line of response which is not true. You could have a detector failure, which would create like a line in your sinogram image, like a black line of response. Yeah, an angle which is not being receiving any signal from either a detector or a detector block. You could also have electronic artifacts in the image construction process.
Okay, so the next part of this is an image. Here, I'll select the image. So what is that? What is causing that artifact? What could that be?
Yeah, I think I've seen this before. I think that this is one of the motion artifacts that I talked about, where there's the patient breathed maybe or moved, and so the registration of the CT image, the PET images, is not true, and so the attenuation correction creates a cold region.
Okay, let's move on to the next set of questions.
Well, Dr. Pooley, the candidate did fairly well on this question, it seems to me, but she stumbled a bit at the beginning. She was very hesitant, and as of course you saw, she asked to start with question number 2. That's perfectly reasonable, and she did, and then backtracked to number 1. It was interesting. She didn't say a lot about the different CT artifacts that might interfere with a PET image, though.
Yeah, that's correct. Yep, she did mention a couple of CT artifacts, but there's many more CT artifacts that that she could have mentioned. And then she jumped to the PET-based artifact, and again, just mentioned a couple of things, which were good: detector failures and electronic artifacts. And I think she was pushing. She mentioned true or events that are not true events, and she could have gone a little more in depth with what that means, and possibly granted there's randoms and there's scatter corrections, and there's opportunities for incorrect scatter correction or problems with the scatter correction. And then she went on to describe, so the next part of the question related to the image of that artifact, and she did get that because that's a pretty common motion artifact, maybe at the end of inspiration of the CT, where the diaphragm is low below the level of where the diaphragm may appear in the PET image. So she did get that.
So all in all, a reasonable performance. She was able to provide answers, and she didn't, I don't think, give any incorrect information, but she might have given a bit more detail and gone a bit deeper into the other types of artifacts or random events, or how scatter might introduce an artifact as well.
That's correct. Yeah, she did reasonably well.
So a passing score, but a low passing score.
I think that's fair.
Very good.
This relates to an artifact seen in scintillation cameras.
Okay, what artifact appears in the planar image of a point source acquired with a parallel hole collimator? Explain the shape of the image on geometric grounds. What can one do to reduce the artifact? So the star-shaped artifact has to do with the photon energy being too great and penetrating the collimator. The shape of the image has to do with the fact that the collimator holes, how the septa are arranged, that they're hexagonal holes, and the reduction of the artifact would be to use a collimator that is better suited for high energy photons with thicker septa.
What if you had a different shape of the holes, say they're square holes on the collimator or even round hole collimators with that?
I think, yeah, that would affect the artifact.
So if you had square holes, what do you think would happen?
Maybe a 4-pointed star.
Okay.
A diamond, I guess.
Okay, let's move on.
The candidate really did seem to understand the issue being discussed here, and it seems to me provided a good answer about the cause of that particular artifact.
Yeah, that's right. She understood that likely a collimator designed to be used with lower energy photons was used accidentally with some radionuclide that was a higher energy photon and produced that artifact. And then she understood that if you change the shape of the collimator holes, that the shape of the artifact would change also.
She did. And I noticed that the examiner didn't ask her to read that last question, but it was presumably because she had already answered it by explaining that the wrong collimator was being used and the solution would be to use the correct collimator. So that seemed reasonable.
That's right. Yes.
Yeah. So that looked like a high pass to me.
I agree. Yeah, it was a kind of a short question, but she seemed to get all the main points.
Right.
Number 1, for a well counter, what is meant by the term minimum detectable activity and how is it calculated? Number 2, how might you determine if the MDA for a well counter is acceptable for leak testing sealed sources? So the term minimal detectable activity has to do with whether the activity amount is able to be discerned from the background. So it has to be a certain amount above the background rate. So it's a measure. It's a calculation of 3 times the rate of the background over the time of counting. And so it depends on the background and the area and also the amount of time for which you're doing the counting. And I think a square root factor in there too.
Okay.
So how might I determine if the MDA for a well counter is acceptable? You would want the threshold for the leak test to be at least the MDA. You would want to make sure that that the count time that you're using is long enough to give you an MDA that's appropriate.
So what is that threshold? Is there a regulation?
Yes. What is it? I don't know. I just did leak tests, yesterday. Did I look at the number?
So if you don't have it, where would you find it? Where would you start looking for it?
Where would I start looking for it? Good question. I would look under probably NRC publications and regulatory guides from the NRC because this has to do with control of radioactive sources, and that's what the NRC is about.
Okay. Any other documents that has a lot of information?
Yeah, so the Code of Federal Regulations probably has stuff like this, and we're in an agreement state, so I'd probably look at my state regulations first.
Okay, so now part 3 here. Here's question 3.
A well counter has a minimum detectable activity of 10 nanocuries for cobalt-57. Should this well counter be used for leak testing cobalt flood sources? Well, it depends on this threshold, which I don't remember, but if the threshold after I looked it up were above 10 nanocuries, then I would be okay.
And the other possibility?
So if I didn't have the correct minimum detectable activity, then I couldn't use it for leak testing, or if the threshold were below 10 nanocuries, then I couldn't use it for testing cobalt flood sources.
Okay, and what would your next action be with the detector?
Probably increase the time that the count is taken.
Yeah, so you mentioned that's one way to do it, right? Question 4 here. Any other ways you can any other change in the detection?
I could try minimizing the background, remove other sources from the area, or shield the well counter.
Okay, let's move on to the next topic.
Very good. Well, again, the candidate knew quite a lot about this topic. The place I saw that she stumbled was quite obvious. She didn't know the threshold for detection and was not really clear on where she would look to find that threshold value.
That's correct. She knew that it existed somewhere. She threw out NRC and came around to CFR, Code of Federal, Federal Regulations. But she didn't mention the specific code, like 10 CFR 35.67, which does, provide a value to the licensee that they should look for. So she didn't know that. And because of that, she wasn't really able to answer fully the next part of the question, which provided a value of 10 nanocuries. And so, right, she didn't know. She went back to, if she knew what the value was, then she'd be able to make a recommendation of whether or not the well counter should be used. In this case, that well counter should not be used because with the threshold level at 185 becquerel from that 10 CFR 35, this well counter should not be used for leak testing that cobalt source.
And she did correctly say that if the threshold
Exactly.
were below the MDA, then it couldn't be used. So it was just a matter of not being able to bring that threshold up in her mind at that moment.
That's correct.
Otherwise, she knew how to determine the MDA, and she had some good suggestions for reducing the MDA, longer counting time, something else to minimize background, and that sort of thing.
That's
So
correct.
again, it wasn't a high pass, but it seemed like a passing score would be appropriate here.
Yes, I agree.
Question 1, in PET inspect, what is the partial volume effect? And question 2, in terms of the size of tumors and other source regions, at what point does the partial volume effect become significant? So the partial volume effect has to do with the fact that we're dealing with voxels of a certain size. And if you have a source region which is smaller than the voxel size, then that source region spreads to fill the voxel because you don't know the resolution of the source below the voxel size. And so the activity spreads out in your image and you get a less intense uptake region.
What about other factors that could affect the partial volume effect? You said voxel size, but the inherent properties of the PET scanner or the SPECT scanner that would affect the partial volume effect.
Probably the resolution or blurring.
Let's say you have voxels that are really small, then the effect you described first would not be a factor if you make them small enough, right?
Right.
So what about the spatial resolution? How would that affect partial volume?
I guess the edges of the tumor would bleed over into the next voxel maybe, and that might, if you've got two tumor regions close together, you might not be able to discern them because the partial volumes are overlapping, and so it all appears as one continuous.
So say if we're going back to the voxel size here, that's an effect. Is there a relationship between the size of the tumors and the size of the voxels? Is there a point when this wouldn't matter?
Yeah, I think we consider to be able to resolve, we would want the full width we would want it's a factor of 3 times the full width half maximum for the resolution of the discernible region. So you take the voxel size and you would want your spacing to be at least Nyquist frequency of 2 or 3 times the voxel size.
Okay, so then there are 2 more parts to this question here. How can you correct for it? What are limitations of these corrections?
I suppose if you knew, I'm not really familiar with this, but I suppose if you knew the size of the tumor, then you could artificially map the activity to be higher based on what concentration you expect in the practical limitations.
So before you go on to that, how would you determine the size of the tumor?
Right. So that's the practical limitation, that I don't know the size of the tumor. You could use maybe a different imaging modality to figure that out.
What do you usually have with your PET scanner?
We usually have a CT for attenuation correction, so I suppose if it were visible on the CT, you might be able to measure it there.
Yeah, so going on to part 4 here, what are the practical limitations? So you can use that CT?
Yeah, I guess the registration of one area to the other may not be completely accurate, and you may not know the outline of the tumor exactly.
Any other limitations on the CT that would make it difficult?
The spatial resolution of the CT, I guess, but it's much better than it is for nuclear.
Yeah, okay. Well, I think we've spent enough time here. Let's go on to the last set of questions.
The candidate seemed to struggle on this question. She understood what causes partial volume effect, how it appears, but she couldn't go into very much detail.
That's right. Yeah, the candidate, touched on just barely how you might correct, but didn't provide a strong answer there. You might suggest scanning a phantom of cylinders and spheres of different sizes and maybe plotting recovery coefficients and something like that. But she didn't go into that. Kind of came around to realizing that you might be able to use CT to identify the size of a tumor if you could see it in CT, but didn't provide a strong answer for limitations to that correction method. And yeah, so she did struggle a little bit with this question.
She did, and using CT, as you say, might be a solution, but of course, if you can't see the tumor on CT, then you really haven't gained anything. So it does seem that understanding the use of a phantom to relate partial volume effect to the size of cylinders of activity is a key aspect of knowledge for a nuclear medicine physicist. I don't see how this candidate could receive a passing score on this question.
That's right. Yeah, this would probably be just below a passing score.
Yeah.
Let's see. This seemed to go very quick, right? We're almost done.
Okay.
So, so this is a radiation safety question here.
Question 1. Compare the regulatory radiation dose limits for radiation workers versus members of the public in the context of shielding limitations. Explain the justification for the difference.
Yeah, so why don't you answer that first?
Okay, so the radiation dose limit for the worker for the year is 50 millisieverts, and for the member of the public, it's 1 millisievert. And the reason for the difference is because the public is, I guess, an unconsenting member and unaware of the risks, not educated in dose reduction principles, and they're not being paid for it.
So the other regulatory limit that you can think of then?
Yeah, there's a limit of in any hour for a public area, you would want a dose limit of less than 2 MR per hour.
Okay, so moving on to the second part of the question.
Your institution is building a new nuclear medicine imaging suite with a new hot lab, uptake room, and PET CT scanner. You are asked to calculate the shielding needed for this new imaging suite. The patient uptake room shares a wall with radiology administration staff. Does the wall between the PET patient uptake room and the administration staff need shielding? Which barriers of the uptake room would require shielding? Probably all of them and quite a bit. Let me look. So you've got radiology administration on this side. I would definitely shield that if possible. I would move a room. I would probably switch this room and this room at the very least. Yeah, I would shield this wall because it's a patient.
Yeah, so what numbers would you design your shielding around? I mean, you can't say now, you can't move the rooms around here now, so you still have the administrators there.
Okay, so radiology administration would be an occupancy factor of 1, which is a high occupancy factor. Not to mention you have the chair on this side of the room. And then this is an occupancy factor of 1/5.
But yeah, but also the radiation levels is acceptable there on the other side, on the administration side.
I guess it depends on whether you consider administration to be controlled or uncontrolled. I would consider it uncontrolled because you don't know who's visiting radiology administration offices. Even if it's just, the director who also happens to be a nuke med tech, at least you know they work in radiology.
How about a receptionist?
A scheduler, this is as far as this is a public area. It's an unrestricted area.
So you would go with what level?
1 millisievert per year.
Okay, then moving on to that, you said the unrestricted, the hallway there.
Yeah. So same level occupancy factor of 1/5, but my guess would be it still requires quite a bit of shielding.
And the patient changing room there, that wall?
Possibly not, because I only see 1 uptake room. And so it's probably the same person in here versus in here. As long as you're not setting another patient in here, I think that's probably okay. But you would want to check on this wall here to make sure whatever's over here is not penetrating through over here.
Okay, then the last question, or the next question, B.
Would your shielding recommendations change if the uptake room shared a wall with an outside parking lot instead of a hallway? Yeah, outside parking lot is probably occupancy factor of like 1/40th. So that's quite a difference in the occupancy factor. So that would probably affect the calculations.
Okay, and then C.
After the shielding has been installed in the suite, administration decides to install a SPECT camera instead of a PET-CT scanner. Will your shielding for the imaging suite be sufficient? Yes, I think so.
What's the difference here? What is the usage difference?
The photon energy is a lot more for the PET, and it also has the CT scanner. The main thing you would want to do is does this mean you don't have an uptake room if you don't have a PET?
Sometimes we do uptake with tech isotopes. Say, there are procedures you do pretty much the same thing as with PET patients, injected uptake, and then it goes into the SPECT scanners.
Oh, okay, then I would absolutely say that the shielding would be sufficient, yes, because of the energy differences.
Okay, well, I think we are done here.
Great.
All right, well, good luck for the rest of your day.
Thank you very much. It was nice meeting you.
You're welcome. Nice meeting you also. Goodbye.
Bye.
Your candidate was much more comfortable with this topic. I appreciated the way she answered that first question about the regulatory limits quickly and was able to give a good explanation of why exposures to the public must be kept at much lower levels than to radiation workers.
Yeah, that's right. And then she was able to continue to describe the areas, and for the administrative area, the administration staff was able to get to the point that she should shield that wall to 1 millisievert per year. And she was able to describe occupancy factors for the areas around the hallway, and especially if it was an unattended parking lot, she got the 1/40th there. So
Yeah,
yeah, go ahead.
I was going to say it also was perceptive of her to point out that perhaps that wasn't a very good floor plan, and
Yeah,
that the uptake room should be in a different location.
that's right. Yep. But then she was able to go on and answer the last part of the questions regarding if the facility decided to switch the PET scanner for a SPECT scanner. It took her a moment to understand what was going on there, but then once she realized, she understood that because the energies in PET are higher, and that the shielding for a PET scanner should be adequate for shielding for a general nuclear medicine camera.
Exactly, and I was pleased to see that she asked for clarification on that part of the
That's right.
question, because
Yes,
it wasn't immediately obvious that we weren't still talking about the uptake room, but in
yes,
fact the scanner room now.
that's right. Yep, yep.
So overall, that seemed like an excellent response to those questions.
Yes, that would be a strong pass, I think.
Very good.